Good. So I want to just to go through the pulmonary embolism. As you know, we have a recent update, NICE guidelines 2020 about principles of management of pulmonary embolism. We do developing pro forma for PE for the trust, and I'll show you this pro forma so we can go through kind of you can see and write or tell me feedbacks and obviously ask questions. So I'm not going to go with the cases because we have quite variety of cases presentation. So I will start from the simple pathophysiology and symptoms and just assessment, restratification. Can you go closer? Sorry. And then we go through the pro forma. So it has quite a lot of information. So I thought I won't go with the cases at the moment because it's just going to be too much. So so P is quite common problem and is has some despite being so common, we sometimes missing this over diagnosis. But certain numbers what we have for now, we have about a year 60, 70 cases per 100,000. We know that in the first hour, 10%, certain even up to 30%, some literatures, people are dying. So when we have a people with massive P, we have to make a decision fairly quickly. Now, obviously, if P is not treated, there's a high risk of mortality. This is a number 30%. It's difficult to be sure what is the number going to be because nobody let people to die with a P. So I don't know how true this number is. So obviously, if you have DVT patients, half of them will develop P in the next few days. So shock, low blood pressure is a poor prognosis and high mortality rate. And even if people been diagnosed with P, there's a certain percentage of people, 25%, will have remain lung clots for longer time and risk of developing pulmonary hypertension in the future. So we need to kind of think about P, recognize and see how better kind of assess people with suspected P and how to be safe and reassured yourself that you have done everything, definitely not P, and people can go home. So the basic principles of the pathophysiology of forming of clots, it's basically, if you imagine pipe or something, which is pipe is very damaged, which is dirt inside the pipe is stuck to the damaged area, or the fluid inside the pipe is very thick or very slow. So this pipe is going to block at some point. The same principles with clot formation. So we have some risk factors, for example, local inflammation or wall damage, surgery, or some infection, cellulitis. Then people mobilizes less, they're using less muscles of the legs. So the venous stasis is there, and then you have some predisposition, people predisposed to have a clots in the veins. Therefore, you have a hypercoagulability state. So if these three things appeared, here we go, we have a clot. We start from the legs and they're traveling up to your lungs. So theoretically, there's a theory that we constantly develop certain mini micro clots in your leg, in our legs, and the body perfectly well able to dissolve it in your legs or in your lungs naturally. But at some point, this clots became bigger, and the body is not able to dissolve, or obviously, and we develop in symptomatic or asymptomatic pulmonary embolism. So there is a simple classification of pulmonary embolism. It's all about your rate of damage to your heart, your blood pressure, how heart is able to cope with the load burden of pulmonary embolism. So massive, it's obviously the blood pressure is low, the body is kind of in crisis. This is it needs urgent treatment. Submassive, the difference is the blood pressure is stable-ish, more or less, but there's evidence of right ventricular strain, heart strain. And subclinical, this is the people which are don't have any evidence of right ventricular strain, no normal blood pressure, and these people mostly would be ambulatory patients or same-day emergency admission patients that we're using certain risk stratification to assess these people for the ambulatory. And I think British Society, Thoracic Society, they set number like 37, 44% of people with PE who survived to come to the hospital. There's a big percentage people, they have subclinical PE, and potentially they should be considered for ambulatory. So let's go through a few of them. So clinical presentation, we know a lot about clinical symptoms of PE, breathlessness, tachycardia, pleuritic chest pain. So certain kind of explanation of the pain, because not always we'll get typical chest pain. We can have maybe a little bit like angina pain, pressure. So what the pleurisy tells us is that PE appeared somewhere in a distal area, distal embolism, when we have a pleural kind of irritation. Breathlessness itself alone, thinking about PE, could be central. And if you have evidence of right heart strain or heart strain in general, when people have a certain coronary artery disease, and their weakest point is a coronary artery, they could have even angina, like retrosternal chest pain. That is point actually, yeah, it's quite interesting, because obviously when we see in people, we're thinking quite often dilemma, is it angina or is it PE? So that is a good point to think about it. Now, syncope is bad thing, but because that means that your heart at some point not able to maintain your blood pressure. So that is, but prognostically, somebody asymptomatic have evidence of risk of VT. Obviously, we're not doing D-dimer on every syncope, but have a certain risk factors or story that you could think about PE or tachycardia. So that possibility, but obviously not if there's no sensible diagnosis, then you can think about PE. Now, the people with heart failure COPD would frequently be diagnosed with exacerbation or deterioration, decompensation. If there's no evidence of heart failure, if people were compliant, and there's no evidence of weight gain, pulmonary edema or peripheral edema, and people with COPD don't have evidence of infective exacerbation, they just suddenly got breathless, and that is history. Maybe you should think about PEs rather than exacerbation of their chronic condition. So, and others, well, I can mention below that, I might just grab a chair. So what we're saying, that PE symptoms, they are not specific. If you can take people with suspected PE and have both breathlessness, as you can see in certain studies, almost similar percentage of people will have breathlessness with PE, without PE, chest pain, pleuritic, substernal. So if you look at these equal numbers with the confirmed PE and excluded PE, having equal number of symptoms. So this just tells you that symptoms is not alone, is not diagnostic. Obviously, you have to put them in account in a whole picture, puzzle picture of the diagnosis itself, and obviously reflect in the future your experience, what the best you can work for you. But as I said, symptoms alone, you should know the symptoms. You should know, for example, fever. People can present with it, so you're aware of that, but you have to put a whole picture, risk factors, stratification, everything together to come up with a diagnosis of possible or confirmed PE. Now we're going to the chest X-ray. Well, we do have a kind of clear plan, for example, that people with normal chest X-ray and obviously evidence of PE, that's most likely, but there's sometimes some changes on the chest X-ray consistent with PE or could be explained by PE. So cardiomegaly in normal chest X-ray, obviously, it's, as I said, cardiomegaly is tricky because all ED patients have AP chest X-ray. So consequently, they will have some heart enlargement with that projection. But 50% people will have a kind of normal or some cardiomegaly. A little bit of pleural effusion could be consistent with PE. Elevated hemidiaphragm, this study showed 7% people have that. Pulmonary artery enlargement, some atelectasis, and pulmonary infiltration. That basically, if you cannot explain that small patch in your lungs with the 15 liters of oxygen, a sudden onset breathlessness for the patient, although maybe he has some raised CIP, wide circuit, maybe you should thinking about PE, because that little patch in the lungs, maybe it is PE related rather than just pneumonia. So it just a thought, can you explain why this person suddenly develop breathlessness and need so much oxygen, and you have seen a little bit of patch, you treat it as pneumonia. Maybe you can thinking about plan B. So chest X-ray, it's rare but occur in this sign of consistent with pulmonary infarction secondary to PE. Just to remember that maybe treat as pneumonia and maybe it's related to PE. Now ECG changes, very common sinus tachy, new IF, very common. The symptoms like typical S1, Q3, T3 can appear, but very rare, 10% of the people, incomplete RBB or RBB, and TIVA inversion V1, V4. I think I found the ECG for you, where you can see that straight away two signs. I don't think it's tachycardic much, but you can see S1, T3, Q3 signs, yeah? And you can see TIVA inversions in anterior leads, a bit of a lateral as well position. So it's quite pretty massive, maybe PE significant, showing right ventricular strain. Yes, you should thinking about that definitely not for ambulatory with these new changes. Okay, so what's next? We're going through. So that is before going to the risk stratification. This is a bare minimum test you do almost for every patient who is breathless or chest pain. Sometimes you can do blood gases or arterial alveolar gradient. It's helpful if you have somebody who CTPA maybe won't be a good idea. For example, it's in my practice, you can do what you want to kind of confirm or rule out your diagnosis. But if you have certain type 1 respiratory failure, and you have pregnant patient, for example, young lady, and you kind of have other reason to thinking about non-PEP. So you have to kind of commit to the diagnosis and can use this gradient, but it's not kind of well used and doesn't have a lot of supportive evidence to it, but it can help you in a way of making decision of, for example, radiation for this patient. So that is only helpful tip. Now we go on to the next one, is actually diagnosis. So far we have a history, we have symptoms, and we kind of thinking about, yeah, it's P. Yes, you're asking yourself, is it the P or something else? So you're thinking hard. And next one, you're thinking about scoring. Use a relevant scoring system to help you identify your next steps. If you think it is P, what help you next? So you can see I mentioned well score, P ruling out criteria, the PERC score and PESI score. So let's go through them and just talk about this. So well score, what does it do? It does help you to identify what to do next, what investigation you to do next. You need to do D-dimer, you don't need to do D-dimer, do you need to do CTPA? So that's well score gives you some leeway how urgently you need to treat people, and do you need to wait for D-dimer to come back or request CTPA at earlier stage. So we know all well score. We're using at the moment well score criteria is 4. If it's equal to 4 and below, P unlikely, you have to ask for D-dimer. If it's more than 4, you go through the CTPA. I do know certain requirements from radiology about D-dimer that possibly will help you if you wish to add at the same time D-dimer to support your evidence if CTPA, for example, delayed for some reason, or you will predict there would be some talk back telling you patient without D-dimer not going to have CTPA. So from the practical point of view, to avoid any delays in management, you can do both, but CTPA should be first, and you put your in request form, you put your well score, and you go speak to radiologist personally and ask radiologist to do CTPA urgently. Yeah, what is he going to do? So the PEC score, what PEC score says, it's only useful when you have very low clinical suspicion of PE. Now, somebody with musculoskeletal chest pain, who's a young age, who pulled the very heavy bags in Sainsbury's, and now he has very sore chest and very painful to breathe. But otherwise, there's no risk factors for PE. Heart rate is normal, saturation is normal. What the evidence show, if you are, they're calling it less than 15% of suspected PE. So he has certain pleurisy or musculoskeletal chest pain. There's no risk factors. The evidence show that even if you're using PERC score, then in this situation, you even can, if it's negative, so you have a zero answer on all questions, you don't need to even ask for D-dimer. So these people can go home with certain analgesia and advice. This is the only helpful tip. It's not like follow blindly. As you know, PE is not something you can follow all the time, kind of rigid steps, because it's very much depends from your knowledge, from patient ability to tell you the story, from all the evidence you have together. It's all certain subjectivity would be there, but it's something you are confident this is musculoskeletal, but you want to show that you use certain scoring, certain kind of reassuring scoring, saying it's very unlikely this is the PERC score you can use for. It's not something for massive P you will go PERC score. It's useless. It's unnecessary. It's only when you have low clinical suspicion you can use this PE ruling out criteria score, which will help you to get people home without doing any D-dimer. You can do D-dimer if you feel like if you're worried still. But if it's very low, history completely consistent with musculoskeletal injuries or heavy lifting, and there's nothing else would put you in any risk factors, it's very reassuring. All right, that we're using PERC score for. And the next one is PESI score. PESI score you're using for people you think should be ambulatory. Even if you suspect in PE and you want to do ambulatory, or you want to discharge people home with a massive PE, you're doing this PESI score to say this person PESI score is 1 or 2, and this is a safe, low mortality risk. That is safe case to get people home. So with confirmed PE or you suspect in PE, so that score is useful for. This is simplified form version, but be honest, using online calculators, it's so easy to do either of this scoring, and that is helpful for people to go home or go back to ambulatory test. That is why we're using PESI score. Yeah. As you can see, that things like age, sex, cancer, chronic lung disease, and heart failure, that is permanent numbers. If somebody has all of this together, they will score certain points. So yeah, a consultant review would be helpful in this situation to assess how well patients and to decide if patients still can go home, because yeah, certain criteria in this PESI assessment are permanent; they can't be changed. So it's obviously better if you on ED, for example, will get consultant review before sending to ambulatory if you're concerned. All right. So a few things about D-dimer. It can be, so it's not very specific, can be raised in a lot of other conditions. So blindly doing scan just to reassure numbers is useless. You have to put a clinical presentation in contents. So it's very useful when it's negative, high sensitivity. So when it's negative, it together gives you with a score and assessment, give you reassurance that P very unlikely in acute setting. All right. So CTPA. So CTPA is useful in a lot of things. It's not only can see PE, you can see other causes for breathlessness. In 60% can give you a result for other causes of breathlessness. So when you laid out all your structure of assessments and you come to the P, it will give you set answers. Obviously, you have to put it in the right kind of structured path, that you've done all things assessments correctly to get to the CTPA. And obviously we keep in mind radiation risk here. Okay. Because, so just got a few pictures just for the experience. Obviously I put some arrows, you can see it, but you can see tiny bit of this grayish dots in the middle of vessels. That is PE. And that is PE bilateral PEs, yeah. Next step, that what I put here is about you doing perfect pathway. So you've done your D-dimer assessment, D-dimer negative, P excluded. This is always certain percent people in 3 months' time will have P. Tricky study, possibly they all without any mortality, just the study people had the scans after 3 months, which show that if P negative in 3 months' time, 0.5% will have non-fatal VT. And even the CTPA was done and it's negative. In 3 months' time, 1.3% would have positive scan for Ps. So nothing perfect in this system, but you have to have a system. There's small percentage. So it's nothing you would do best. But if you follow this criteria, this is a nice guidelines, and you do your best practice, that right thing to do. You can't just keep people with positive D-dimer forever, waiting for D-dimer, waiting for P or PED. So you have to be sensible in all steps. But as I said, I just want to show that nothing perfect and 100% guarantee. But when you follow right things, right steps, you've done everything right, you judged the situation correctly, there's nothing, yeah, you've done all right or good things. So in summary, so you got your all the steps. We're coming up to the management now. And the important things with the management, it's risk stratifications. So the things I'll go through risk stratifications, and we go to the pro forma, where mention management and treatment, massive treatments. So I thought I wouldn't put in a presentation. We just go through the pro forma, just have some ideas, and you will write or ask me a question, give me feedbacks about it, because it's still in under review. Would be nice to hear what you think about it. So with the risk stratification, we're talking about certain things we have to pay attention, which will make us to rush and treat patients right now, or start treatment with anticoagulation and wait for the scan. So it all depends how people present and what their problems are. And blood pressure is a big thing, yes? So we know about massive Ps, this is a criteria, massive P. So we're talking about blood pressure below, systolic blood pressure below 90 millimeter mercury. And these people have a 50% mortality in the next 3 months. And another criteria of massive P is a systolic blood pressure drops by 40 millimeter mercury for more than 15 minutes. And these people have as well certain percentage mortality. So Any evidence of blood pressure instability is all bad news. Yes. The next step, we start talking about troponin, proBNP, and studies show that abnormal troponin and proBNP showing right ventricular strain, showing worse outcomes for these patients. And another things, important things on CTPA, it's pay attention to the right ventricular strain. And I'll show you images. Basically, what they're trying to say, that size of the right ventricle bigger than the left ventricle. And I will show you, so I made a picture, I found the pictures for you, just to have some idea. Obviously, if you're suspecting right ventricular strain, you have a troponin raised or you have ECG changes, and radiologists forgot to mention that you should ask radiologist if there's any right ventricular strain, because this is what makes you prompt you to get echo in hospital. So this is a CT scan which showed right ventricle and left ventricle. And as you can see that the right ventricle significantly larger than left, and then 1.5 times for sure. So normally right ventricle would be about this size, so it's increased twice. These are similar findings. So right ventricle and left ventricle. You can see right ventricle significantly dilated. And this can uniquely show that the interventricular septum, which normally will go a little bit to the right ventricle, is bowing to the left ventricle. That is completely, it's bad news. It's actually close to significant instability right ventricle, similar kind of cardiac tamponade. So that is bad news for sure. Hopefully radiologists will report that. And other images we continue. I just want to show you echocardiogram. Now, the echo shows this is the left ventricle, left atrium, right ventricle, and right atrium. And normally, right ventricle, approximately this size, he would be significantly smaller by 2/3 than left ventricle. So as you can see, the right ventricle is dilated. And maybe interventricular septum a little bit too straight or a little bit moving towards left ventricle. So it's just basic things for somebody who is not cardiologist, but able to kind of hold the probe and identify that right ventricle is bigger than left ventricle. This is what you need to at least to see to put together if people need thrombolysis or not. Why I'm talking about right ventricle and strain of right ventricle, because that is prognostic factor of the survival for patients. As you can see that people with a subclinical PE, so no evidence of right ventricular failure, their prognosis is quite good. But people who have any evidence of right ventricular failure, I mean, 30 days mortality is significantly low, significant. Yeah, so I mentioned 50% people with massive PE won't survive in the next 3 months. So that is important. The recent guidelines, it highlights important, identify right ventricular strain, troponin, ECG, CTPA, echoes, anything just to identify these people at high risk, okay? Now, so I'll come up with my presentation. I will close this one, presume. Don't save. I'll show you Proforma. Where are you? I need to open Proforma again. Okay. Sorry, it doesn't come out easily. Any questions? P.
My question is, in terms of risk classification of if the risk is very low, I mean from the well score and then you needed to send for the D-dimer. Is there any situation whereby the D-dimer is negative, and yet you still have to, patients still have to go for CTP, even though maybe you're still suspecting, and the D-dimer is negative, which you rule it out?
So the question is, if you suspect in P, and not the D-dimer negative, but clinically you suspect in P, is difficult because you have to put other clinical presentation with. So if there is no other reason for breathlessness, and I presume the D-dimer negative could be somebody who possibly has a chronic P. And you are the people, normally what comes on in this situation, the people will have a lot of investigation for asthma and interstitial lung disease, and echo maybe will come up with the right ventricular strain. Then you can thinking about P or pulmonary hypertension. That is, but negative P, as I said, is very reliable test for acute breathlessness. If people come up with acute breathlessness, is a very reassuring test. And I think if you're concerned, you just have to share your concern with the senior doctors. Okay, so anybody seeing Proforma? Oh, guys, are you seeing Proforma?
Yeah, we can see it.
Oh, wonderful. Okay, good, great. So that is just working Proforma. There's about 4 both-sided pages, so 8 pages in total, but 4 together, like booklet. I can see that. So you can start that Proforma at any stage of admission on A&E or in hospital, and this Proforma just basically highlights start from the escalation plan, which is one of the kind of best practice situation when you have to identify where we're going with that, because it's quite serious diagnosis. So you have patient's ID. So this is the one that gives you just basic plan steps wise. It's advisable how to follow that first. So you suspect in P, you're doing your Wells score stratification. Now, if you have very low suspicion, for example, a Wells score is very low, and you are not concerned about this pleurisy, then you can do PERC score, P rule out criteria scoring. If it's all negative answers on that PERC score with low clinical suspicion, you can send people home. If you're still worried and you don't have a senior with you, you can do the D-dimer, but it's all would be based kind of in general your picture, and if you're confident it's a pleurisy or musculoskeletal pain or injuries to the chest wall. So it's up to you what to decide. For example, somebody has a bruised chest for whatever reason and you're doing the D-dimer, I don't think it's going to be negative as such, but clinically you know that patient been hit or hurt some way or another. So it's just to thinking about logically, if they're well stable, there's otherwise no problems, and chest injury, do you need to do D-dimer or not? So the Wells score, otherwise, if you're still worried and you kind of thinking about P, so you're doing Wells score and you stratifying, is it below 4, D-dimer, if it's above 4, you go into the CTPA. So here, situation, normally we won't be able to get CTPA in the 4 hours. It's impossible. So if you are requesting CTPA, you have to thinking about treatment dose, Clexane, or you have committed radiologist telling you, I'll do it in 15 minutes for you. It's fine, but make sure you give anticoagulation treatment if you're requesting CTPA, or if the D-dimer positive and you're requesting CTPA. Yes. So so if CTPA positive, great, you have diagnosis, you start treatment. If CTPA negative, but you're still worried that the D-dimer is sky high and you're still concerned about risk, too high risk of VT, you can do the Doppler scan. But if it's all reassuring, you have to think about other diagnoses. Don't forget other diagnoses, okay? There's no diagnosis CTPA negative. You have to thinking about other diagnoses, yeah? When you come up with with a well score, you're thinking about CTPA need to be done, don't forget to do PESI score. PESI score will help you, and obviously other criteria for ambulatory help you to identify people for ambulatory. For ambulatory patients, PESI score 1, 2, there's no evidence of right ventricular strain, and obviously people can walk, can talk, have a telephone number, they have a house, and they can come back, and they understand what's going on. Yes, it's not like somebody is very homeless or very confused or IVDU. They are staying in a hospital. Yes, you're not sending them home. So that is situation. So, and on the bottom I mentioned about importance echocardiogram if you have evidence of right ventricular strain. That is where we're going from the risk stratification. When you have a patient unstable blood pressure and the evidence of right ventricular strain. So I will come up to the massive P's. So I mentioned about blood pressure. You can read it again. Systolic blood pressure below 90 millimeter mercury, or drop systolic blood pressure more than 40 millimeter mercury for more than 15 minutes. You're giving bolus of fluids to these people, 500 mils. You're suspecting massive P. You're doing medicals. You're getting people around who can help you with the management. And in particular, you obviously do an ABC score, fluids. You're getting people who can do echo bedside. Is great if you're cardiologist or you have certain anesthetist to have a certain training in bedside echoes. It's helpful with the cardiac arrest in general to have echo skills, certain basic echo skills to recognize right ventricular strain. Don't forget, if you're in this situation, you are doing echo, don't forget to record your images on the echo machine for the future references, because it's a quite important step to confirm in right ventricular strain. You can record the evidence on echo machine. Yeah, I think if you are involving anesthetist doing medicals and getting somebody of them can maybe have some skills of echo, or you are going to pursue to learn skills of echo, that will be helpful in general situation. So in this pro forma, there are 2 places mentioning about thrombolysis. So with massive P thrombolysis, we're using alteplase. In the hospital, place for thrombolysis, as far as I know, it's CCU, but we can involve with CCU nurses to help you with thrombolysis. If patient's too unstable, presume they can come down, or patient has to be urgently transferred to CCU. Possibly anesthetist can help with that if CCU booked or any other problems, but we need to get med-call, get consultant on call to help to manage these people urgently. If thrombolysis is contraindicated, well, that pathway never been checked. And there's a few discussion been with our radiologist, and they said, we can do it. And then they forgot to mention that we don't have equipment for that. So they can do it, they can do everything, but you have to have special equipment for the catheter-directed thrombolysis. So the plan B is a Brighton, and I presume they're not going to say, they say yes, and technically it's difficult because, as you said, within the first hour, certain percentage people are dying, and if to go to Brighton will take you another hour, just finger cross, it's difficult. It's a difficult situation. Obviously, you will contact Brighton and arrange whatever needs to be arranged, blue light, etc. But it would be tricky. It would be tricky. But it's plan B, and we have to mention that in a pro forma plan B, just maybe it will help one day. So and I put so the next step would be submassive P. Basically, it tells you any evidence of right ventricular strain or subclinical P. And subclinical P pathway tells you about ambulatory criteria, and then just spends a few seconds to look ambulatory criteria. So somebody is unstable and higher PASI score. Somebody has a bleeding risk factors, for example, liver failure, or they will develop PE while on anticoagulation. Somebody with renal failure, homeless, IVDU, problems, mental problems, no phone, no home. So these people have to be admitted. There's people, I mean, it is quite stressful when you have somebody CTPA referral and you can't hold a patient. That's great. So otherwise, if you patient needs to be admitted and more they're stable, obviously with need for admission or right ventricular strain. So you do basic things, basic. So you ensure an echo being requested, consultant reviewed, and we do need kind of not forget to talk to patients about PEs, and there's a specific checklist in our guidelines, which I will show you later, because just to remember, because we're kind of not using it frequently, and pharmacists kind of have using this guidelines and kind of giving yellow card and warfarin book if needed, and tick the boxes if patient understand, explain everything. But as well as the doctors, if, for example, nights and there's no pharmacist around, we should do the right management with the patient, right thing for them to explain. Because we did have a case when on Christmas, gentleman was sent home, and somebody forgot to tell him that he has to continue apixaban for his bilateral PE. And he called a week later to GP to find out, does he need more apixaban because it's finished 3 days later. So GP sent it to us to make sure he's stable. And he was fine, and I apologize greatly to him. But it's a good thing just to talk to people, explain what it is, and use I will show you where you can find this many years approved checklist for anticoagulation in our clinical guideline of anticoagulant use in adult. Okay, it's a little bit too much information, but it's something we have to think. It's not just only prescribed on a drug chart and discharge letter. So speak to people, please. Okay, now treatment. This is a treatment for this is basically a copy is from the NICE guidelines. You can find this in NICE guidelines as well. This is, it has to be kind of compliant with the BNF and our local guidelines. But basically the idea is that you anticoagulate people minimum 3 months, and you're trying to minimize duration of anticoagulation only for certain reason. For example, cancer, which still not cured, still on chemotherapy. That step has to be kind of reviewed in 3-6 months stepwise. But if you have provoked PE, then it's no risk factors otherwise. It's make sense to get people anticoagulate for 3 months. With the treatment, it's very important to make sure GP, in our case GP, because we don't have VT clinic, kind of got in touch with patients and acknowledge adherence to the treatment within the week, and then in 3 months' time, when treatment due to be finished, reviewed. That is ideal follow-up for the patient, typical for PEs. So now NOACs or DOACs is prevalent, and we using it not only for non-risk PE, but for cancer patients as well. As you know, that we're using Clarke twice a day, 1 milligram per kg, which quite a lot of injections, especially if they're having not one injection or two, they're now 120. So we're having 4 injections a day, and then waiting for oncologists to change a DOAC, because oncologists been using DOACs long time. So this is a kind of basic graph in the NICE guidelines. So in our trust, we're using apixaban, rivaroxaban. We don't need to use pre-Clarke before that. The bigger tranidoxaban do need a little bit of Clarke before switching. and obviously warfarin still on the list. With a renal failure, you can apply the same treatment, but if it's GFR less than 15, you have to consider warfarin, Clarke, or unfractionated heparin. That is important. Yeah, obviously in consensus with the renal team. The other said cancer patients now favored towards a DOAC, consider DOACs, but still, if you feel better with low molecular heparin, you have to discuss with the cancer patient itself what he would prefer, what he's happy with, and oncologist who possibly maybe will be more in favor late Clarke treatment rather than DOAC. So it's all kind of patient experience, your experience, oncology, who is going to look after their patient. And people with kind of complicated situation, antiphospholipidemia syndrome, warfarin is the main, Clarke and warfarin is the main treatment to continue. The other basics, you can find it in NICE guidelines. These are bottom boxes I have to mention because you have to remember about contraindication for anticoagulation and speak to hematologists if it's complicated cases on specialties, because obviously you don't want to cause any harm. And if anticoagulation contraindicated, you have to think about IVC filters. So IVC filters are indicated if you cannot treat patient, if you cannot anticoagulate them, they had recent bleeding, subarachnoid hemorrhage, or GI bleed, or they are the maximum top-notch anticoagulation, warfarin, INIs 3, 4, and they still have VTE. Then you have to thinking about IVC filter. That thing is important, that these people have a date when IVC filter has to be reviewed and considered to remove. The biggest problem with IVC filter is easy to forget, and people 10, 20 years later coming back with inferior vena cava obstruction with a lot of collaterals. Basically, the best practice trying to say, don't forget that IVC filter to be reviewed and removed if necessary, okay? If it's permanent, circle permanent, not for further review. But if it's temporary, for whatever reason, recent bleed, for example, which will be treated, coiling or any kind of GI treatment, so the IVC filter literally needs for 3 months or 6 months, and then can be removed. So that situation, people don't need forever IVC filter. So let's go back. Hopefully I will be faster for you now. This is my favorite bit, ambulatory same-day emergency admission. So we have a few names, but hopefully with all this COVID situation, we'll find one name everywhere. So I have mentioned criteria. So the referral, for those who don't know, on eSearcher we have fill-in form for ambulatory referral, and then you have to email to us. Our email has different name. It's called AEC. So it's for me sometimes trouble to find it. So we have few names, so apology for that, but we'll change it in the future. In ambulatory, we will repeat PASI score again to make sure people are not getting worse. We're looking for risk factors, partially because we need to look for reason for unprovoked VT and thinking about maybe screen for malignancy. So we look for the risk factors if there is provoked evidence. So these people will have an anticoagulation for 3-6 months. So examination, if we're talking about unprovoked, needs to be thorough in the examination, particular for breast examination and in female and external genitalia in males, to rule out any problems. So with the unprovoked PE, if you're thinking about cancer, basic blood test and examination and history is the most important part. That what you examine people and asking the question, that is the most important part, not scanning them every VT, DVT scans. and reassurance. No, that what you're asking, what you're documenting in your notes, if patient doesn't have any evidence of cancer, no symptoms, no complaints, that is good enough. So, so I have stressed enough how important reporting CTPA right ventricular strain, and we're talking about if we have time. We don't have time. Oh my goodness. So maybe later, another time. So, and this is just put cancer unprovoked PE investigations. So it's a cancer questions. Females, for example, above 60 should have PSA. Ladies should have cervical screening if they're young enough. If they're older, they need to have a breast screening test done by GP. So you're doing all the questions. If you're suspecting any abdominal problems or hematuria or bilateral DVT, which is concerning, or PV bleeding, so you're referring people to set investigations. But focus clinical examination, focus questions, and blood tests are the most important things. And this is a page. If somebody, you guys, if you have time, I would appreciate it. I won't take long because it's almost 2 o'clock. So this is a page gives you about massive PE and thrombolysis. So the only thing I can stress enough, it's about assessing people. You are deciding to do thrombolysis. You're doing consent form. Mention people that have a certain risk of bleeding. 10-15%, especially a small percentage of bleeding in intracranial, and death. That kind of is important to document when we are going down. But basically, when you have unstable patient, you're trying to involve as many people together. If patients stable enough, CTPA. If it's really sick patients, you do medical. You're getting people around who can do echoes. And obviously informing consultant about situation for thrombolysis. So if thrombolysis, as I said, 10 and 90 alteplase in massive PE, as I said, plan B would be if you can't do thrombolysis, you speak to Brighton. This is a tick boxes when you're stressed, you can't think. There's a tick boxes brief here on the page. So you've everything done, you check blood pressure, you find enough evidence for thrombolysis, you look for contraindication of thrombolysis, because at that time you be a little bit in hurry, a little bit anxious, and it's understandable. And you obtain consent for thrombolysis, and you done thrombolysis. That almost everything. And at the end, I mentioned about cardiac arrest. Alteplase in case if you have the situation. So you have with cardiac arrest, you give 50 alteplase, and from the moment you give alteplase, suspected PE patient, you have to continue resuscitation at least for 60 minutes from the administration of alteplase. That is the latest kind of update about ALS. Yeah, so we have used NICE guidelines, and we use Dr. Gray's and hematology recent clinical guidelines for anticoagulants, and yeah, and ESC as well documents. So it's been put together trying to make it so simple and approachable, because PE can have a lot of opinions and assessment, and but that is kind of minimum important information in in few pages. If you have a few moments, I can show you hematology pathway checklist for anticoagulation, or if you not, maybe guys will go with the questions, because really 2 o'clock, we possibly need to go in clinics now. So are you happy to do with the questions, guys? Or there's nobody there anymore and I'm alone?
We have okay.
Okay, I do want to crack on with the questions then.
Vic is all right.
Okay. Okay.
Um,
Yeah.
yes, it's rough here. I would like to share one of my recent experience with one of the patient. This is with regards to PE. Actually, this patient came in with an obvious COVID changes on the X-ray, desaturating, a bit of chest pain. So this is a young patient, around 55 years old, not much of a cardiac history. Everything can be explained by PE. The chest pain that he experienced, it could be just because of his breathing and muscle problem there. As a result, that he's straining this. um, Nothing on ECG that would point out cardiac, no significant history. And at the end, we did a troponin just to clarify things, which is very low. However, they did the D dimer at this point, and obviously, I've reassessed the patient. I think like 2 or 3 times, and I was really worried that because of the COVID, we might be having some intercurrent PEs as well. So we requested the CTPA, put him on an anticoagulation. So I was surprised to see the D dimer is very low. Actually, it's about 280 or something. But we did commit, and we did the CTPA, and the result was as I expected, that there's PE there. So I don't know. I mean, from the rest of the consultant here, any experience other than just pure COVID?
Yeah. Yeah, I can't explain either, because I've seen COVID patient with the dimer 1000 and 1000, and CTPA was negative.
That's right. Yeah.
And I suspect with COVID patients, they do have a chronic kind of micro emboli anyway. And if patient developed PE far long ago, before or with the developing of COVID symptoms, and several weeks been in the ward, and with the chronic or settling COVID, possibly the dimer was negative. So it's, as I said, you have to switch on your thinking, because with chronic PE is tricky, because the symptoms could be weeks or months, and people are stable, and the dimer would be negative. It just, as I said, you have thousands of numbers of the dimer, and CT was negative. We had a patient, obviously we have chronic friendship, great friendship with radiologist with ambulatory CTPA, and frequently we will be refused to do CTPA, partially because of the history and the way CTPA requested, without well score, without risk factors, no D-dimer mention, that the radiology will question why we should do it. And a lot of things like patient not tachycardic, his Doppler scan was twice negative, why we should do it, and the dimer slightly positive, and we insisted for a few days, and finally we got it, and CTPA was positive. So it's difficult. It's all about the more I the more I have this patients with VTE, the more you have kind of self-doubt. But in general, when you're using in acute typical presentation of breathlessness, dyspnea, pleuritic chest pain, when you have a typical presentation, the dimer very reliable and helpful. When you have long-standing breathlessness and you're thinking about COVID, pneumonia, and people still breathless after antibiotics and treatment, and if the dimer negative, it's difficult to be in a chronic situation, rely on the D-dimer alone. If patients still in type 1 respiratory failure, and you still have it's if you go CTPA, go for CTPA. But there's no golden rule, unfortunately.
Thank you, Vic. I mean, that's very helpful. I mean, obviously now, because of I'm worried about COVID and PE. I keep on looking, but obviously, best clinical judgments still, is this important thing. Thank you, Vic.
Yeah.
Thank you.
I heard that ITU or anesthetists, they're doing middle dose of Clarke for COVID patients, something like 40 milligram BD, which made me make a sense. Some of the trials they're doing treatment Clarke anyway for COVID patient, because as I said, I suspect that there is a constant chronic sort of throwing micro VT pulmonary emboli going on, and this patient at risk that little lungs left to secure, they may be at risk. But as I said, this would be little evidence, based on the consultants' kind of knowledge, confidence, and what is the best. So ITU at the moment, as far as I know, I've done my research, they're doing a middle dose of Clarke, not full dose, something middle dose. Yep, Dr. McIntyre.
Victoria, thanks, Victoria. Very helpful. 2 questions, and I may have missed them. Sorry if I missed it when you mentioned it. With regards to treatment, there is no distinction made between the smallest of PEs and everything apart from massive PE. Is that right? So you could have a big PE, bilateral, saddle, right ventricular strain on the CT, and just give them a Pixaban.
Yep, that's it. They put a consider. I think they're not confident. Don't use Clarke.
Okay.
But if patient with the right ventricular strain, he's going to be in a hospital, and I agree with Dr. Gray. So better start with Clarke because you don't know complications. They had enough problems anyway to cause any harm. So if they're in hospital, I think Clarke treatment dose would be safest, and then send home with it.
So doing 5 days of Clarke and then edoxaban, presumably. Okay, and the second question was, how do you decide between 3 and 6 months?
Personally, I based on the risk factors, if they're still there, present, and as it's a massive PE, I would consider longer.
Yeah, thanks.
Yeah.
Thanks.
Okay, anybody else? All right, guys, thank you very much.
I can't come here. I just wanted to, hello? Yeah, hello.
Yeah, sorry.
Yeah, it's the question about what do you call it? The D-dimer that Dr. Goles was talking about. I just wanted to contribute to say that by what he's telling us, his clinical judgment is that the patient has a PE. Now, if your clinical judgment is that the patient has a PE and their Wells score is 4 and above, you do not need to do a D-dimer. And the thing about D-dimer is that it has a good negative predictive value. So 95% of people with a normal D-dimer will not have a PE, but 5% of them may have a PE. So if you depend on your D-dimer alone to say that because the D-dimer is normal, 5% is 5 in 100 is 50 in 1,000, and it is 500 in 10,000. So it's still important that your clinical judgment is used first before talking about D-dimer. And it's only useful when your Wells score is extremely low. So that's just a bit of a nugget of information about the D-dimer use. So as a clinician, if you're confident that they have a PE and the Wells score is high, the D-dimer is of no value at all.
Yeah, I think in hospital patient would have a high Wells score if you're suspecting PE and they've been bedbound for 3 days.
Yeah, and you have to just add the other clinical factors and you go ahead and request it. Yeah.
Okay, thank you very much. Thank you. I think I don't have any more questions. Yeah, thank you, guys. Thank you, everybody, for coming. Okay, thank you. Bye.
Thanks, now.
Cheers, bye.